We typically think of a restless night as a neurological problem, but the resilience of the skeleton is built during these hours of rest, and without them, the bones enter a state of metabolic vulnerability that eventually manifests as physical structural trauma. To understand how sleep architecture dictates bone density, we turn to the clinical framework presented by Assistant Professor Dr. Farhad Mustafa Musa Atrushi, a board-certified orthopedic surgeon. Long-term clinical research reveals a distinct pattern. Patients suffering from chronic sleep disturbances experience a statistically higher risk of physical falls and fractures. This data is highly concerning because the increase specifically includes severe structural failures, such as spinal fractures. The elevated fracture risk persists even after adjusting for a patient's baseline hip bone density and their general likelihood of falling. This points to a systemic degradation rather than simple clumsiness. However, the clinical evidence shows an association, not absolute proof. Insomnia alone does not directly cause osteoporosis in a vacuum. Instead, poor sleep activates what we can call the osteo-sleep axis. This is a cascading matrix of biochemical changes, biomechanical deficits, and comorbid pathways that collectively degrade bone health over time. We will synthesize the evidence behind these three distinct mechanisms and then test the framework against the latest clinical data from a comprehensive 2024 review. Accurately diagnosing and treating modern fracture risk requires orthopedic professionals to look past the skeleton and carefully evaluate a patient's neurological sleep architecture. The first mechanism in this matrix is the biochemical pathway. A healthy skeleton relies on a continuous process called bone remodeling. It is a delicate state of homeostasis where the body breaks down old bone tissue and simultaneously builds new bone to replace it. Poor sleep introduces a primary disruptor to this balance, a chronic elevation in circulating stress hormones. When cortisol, the body's primary stress hormone, remains elevated through the night, it acts as a heavy weight, suppressing osteoblasts, the nodes responsible for building bone. Homeostasis breaks. The scale tips, creating a gap where breakdown outpaces repair. Sleep deprivation also triggers a secondary consequence. The system is flooded with red inflammatory markers, which further inhibit the activity of the remaining repair nodes. This chronic inflammatory state disrupts the broader hormonal balance required to maintain normal skeletal density. Ultimately, chronic insomnia suppresses the skeletal remodeling process, effectively shutting down the body's ability to repair its own daily microdamage. Moving from the cellular level to human behavior, we reach the second mechanism, the biomechanical pathway. Chronic poor sleep leads directly to profound daytime fatigue and sluggishness. The immediate behavioral consequence of this exhaustion is a severe reduction in daily physical activity. This kinematic model demonstrates mechanical loading. Bones require physical stress and impact from movement to stimulate density generation. As impact waves travel up the legs and spine during a walk, they trigger the specific cellular signals needed to build mass. When fatigue forces the body into a sedentary state, the bone is starved of this physical stimulus. The generation indicators fade into a warning color, representing skeletal atrophy. Beyond atrophy, tiredness introduces an acute physical danger. Exhaustion compromises the nervous system's proprioception, resulting in poor physical balance. This lack of coordination translates directly into a much higher statistical risk of suffering a traumatic fall. Chronic fatigue creates a dual biomechanical threat. It thins the bones through disuse, while simultaneously making a high-impact catastrophic fall highly probable. The third node of the matrix involves comorbidities, specifically isolating the effects of sleep apnea. During an apneic event, a patient's breathing repeatedly stops throughout their sleep cycle. This is an independent physiological trauma that introduces an entirely separate layer of skeletal risk. This time series graph tracks sleep hours against blood oxygen saturation. With sleep apnea, we see severe downward spikes where oxygen levels plummet into a dangerous clinical zone. Expanding at the bottom of these dips reveals what happens on a microscopic level. These repeated drops in oxygen trigger intermittent cellular hypoxia throughout the entire body. This low oxygen environment actively suffocates the precise bone repair mechanisms that we're attempting to function overnight. Left untreated, sleep apnea turns the restorative period of sleep into an asphyxiation event that actively starves skeletal regeneration. A comprehensive 2024 clinical review serves as a modern stress test for this multifactorial model. The standard clinical assumption has historically been that excessively short sleep is the primary driver of low bone density. But this chart plotting sleep duration against osteoporosis risk reveals a paradox. The strongest, clearest link to lower bone mineral density is actually found in a massive peak on the far right, long sleep duration. Conversely, the data points populating the short sleep side of the curve are highly scattered, lacking a definitive universal correlation. However, one specific cluster shows a link between short sleep and low density specifically observed in men. We can deconstruct this paradox by looking at confounding variables. Long sleep duration is frequently a byproduct of the low physical activity, chronic illness, and sleep apnea that directly destroy bone tissue. Excessively long sleep is not a cure for fatigue. Rather, it acts as a glaring clinical biomarker for underlying systemic and skeletal decline. Stepping back to view the completed matrix, we see how chronic poor sleep degrades bone via cortisol, inactivity, hypoxia, and falls. Mitigating this fracture risk requires a proactive protocol that addresses both physical lifestyle and sleep hygiene at the same time. The first behavioral intervention is establishing regular, uninterrupted sleep architecture to normalize those circulating stress hormones. The physical intervention requires targeted weight-bearing exercise and strength training to forcibly restore mechanical loading to the skeleton. Nutritional intervention is equally necessary, ensuring the patient has an adequate supply of raw materials, specifically calcium and vitamin D. However, there is a clear threshold where conservative lifestyle management is insufficient, and care must be escalated. Specific clinical red flags require immediate medical evaluation. These include ongoing insomnia, severe daytime sleepiness, loud snoring indicative of apnea, and any unexplained fractures. Bones do not exist in a vacuum. Their structural integrity is dictated by the entire systemic environment surrounding them. We extend our thanks to Assistant Professor Dr. Farhad Mustafa Musa Atrushi for synthesizing this clinical framework. True orthopedic care extends beyond the skeleton itself, requiring us to heal the body's time offline just as rigorously as its time in motion.